Hello and welcome to one more lecture of hematology. And today we are going to start discussing, rather, I should change this one, that is hematological malignancies. Okay. So, hematological malignancies, of course, like the malignancies which are related to blood, and hematological malignancies, like by definition, are basically tumors of the hematopoietic and lymphoid tissue. So, like any type of malignancy which is occurring either in your lymph nodes or either in your bone marrow are called as hematological malignancies. So, uh, generally speaking, um, like there are many definitions, for leukemias and lymphomas and wide variety, like different books they give different definitions. So, but like whenever we talk about the blood cancers in general or hematological cancers, so these are the cancers which begin in the blood forming tissues. Of course, like what are the blood forming tissues? There is like the bone marrow, there's the cells of the immune system. So we classify them according to the same things into leukemias, lymphomas, and what you can say, myelomas. Okay, so again, there are different classifications, and this can be very complex type of classification. But to make it simple and to make you guys understand, I'm going to keep it simple. So generally speaking, it could be lymphomas. Okay, it could be leukemias, and it could be myelomas. Okay, so now by definition, um, lymphomas are basically the malignant cells. uh, like, okay, I can write it over here just that you guys can remember. So it is malignant cells which arise in lymph nodes, okay, and uh, lymphoid tissue and lymphoid tissues, and after that they may spread anywhere. Okay, for example, after arising from the lymph nodes or the lymphoid tissue, they can spread anywhere. For example, blood and bone marrow. Okay, so this is the definition for leukemias, lymphomas. So how we can define leukemias is, again, like these are the malignant cells which arise from, in this case, from bone marrow. Okay, and after that, and they may spread elsewhere. Again, when I say elsewhere, so again, what I mean to say is like blood, um, lymph nodes, okay, or lymphoid tissue. Okay, so see, until now it is quite clear. See, lymphomas arise from the lymph nodes or lymphoid tissue. Leukemias, which arise from bone marrow. Okay, and after arising from there, of course, like they may spread, um, what you can say, to anywhere. Okay, anywhere. So you can say uh, what it means. Like no matter it is leukemia or lymphomas, um, they can arise from lymph nodes or lymphoid tissue, or in case of leukemias, they can arise from the bone marrow, but they can spread elsewhere which are the same things, like again the blood, the bone marrow, the lymph tissues. What is lymphoid tissue is basically, these are the structures that support the immune system. Okay, for example, the spleen, the tonsils. Okay, all these structures are called as the lymphoid tissue. So uh, this is the definition of leukemias and lymphomas. Okay, whereas the definition for myelomas is basically, uh, these are myelomas are also called as, uh, like the very common one which we are going to study is called as multiple myeloma, which basically is a cancer of plasma cells. Okay, so you can say myelomas are basically the cancers of plasma cells. What are plasma cells, guys? These are those cells which produces antibodies in the body. So these are like the basic definitions. But in reality, the situation is not that much is simple. Rather, it is a little complex. Uh, for example, uh, um, it's not like this that, for example, if you found the malignant cells in lymphoid nodes, so you are going to label it as lymphomas, or if you are going to find the malignant cells in bone marrow, you are going to label it as leukemias. Okay, so we can say like it cannot be solely defined on the location of the malignant cells. Okay, uh, like what kind of hematological malignancy the person have, but what is done in reality, you can say, is like they are classified on the basis of the characteristics of cells, like type of cells which they found. Like, of course, what are the characteristics? Like they are going to do the hist, hist, histology of the cells. Okay, they are going to do the histo chemistry of the cells. Okay, they are going to do the immunotyping of the cells, as well as they are going to see the genetics of that cell. Okay, so like what I'm saying is simply, uh, like once they found any cells in the body. Okay, no matter they found it in the lymphoid nodes, the lymphoid tissue, or the bone marrow, uh, they run a lot of investigations like histology, histochemistry, immunotyping, phenotyping, uh, genetics, molecular changes, and all these things. Okay, so then they classify uh, what kind of, what you can say, malignancies there. One more thing I would like to mention: not all the books they classify them in this category, in these things. Rather, what you can say, one of the classification is based on from which lineage the cancer is arising. For example, it could be myeloid disorder, it could be lymphoid disorder. Rather, I would talk like here about that thing. You can say uh, one more classification. Okay, hematological malignancies classification of hematological malignancies. Okay, so what I'm doing is like I'm going to talk about one more classification, or one more way by how these things are classified. So there are two lineages, like, if uh, one is called as the lymphoid lineage. Okay, a lymphoid lineage, and one is called as the myeloid lineage. Okay, so lymphoid lineage and the myeloid lineage. So you can say like one is are basically the lymphoid disorders. Okay, and one is called as the myeloid disorders. Okay, so if you know what is lymphoid and or lymphoid lineage and what is the myeloid lineage, I think things are going to be easy for you. So lymphoid lineage or lymphopoiesis, for example, like to make it more easy, is basically uh, lymphopoiesis is called as the generation or the production of the lymphocytes. Okay, which is like one of the type of white blood cells, of course. So uh, lymphoid lineage are that lineage which give rise to the cells what you can say, um, the one which circulate in the body and they provide immunity. Okay, the B cells, the T cells, okay, all this one they are called as they are considered as the lymphoid lineage. Okay, so now the myeloid lineage is basically uh, the lineage which give rise to other cells of the blood. For example, the eosinophils, the granulocytes, the basophils, the neutrophils, okay, and all this one. So, like this, that is called as the myeloid lineage, and the one is called as the lymphoid lineage. So, of course, like when the disorder is basically the myeloid cell, so we call it as myeloid disorders. When the problem is like a lymphoid lineage, it comes from the lymphoid lineage. We call it as lymphoid um, disorder. So, myeloid lineage is simply like it mostly give rise to all the blood cells. Okay, and like whatever is circulating in the circulating in the blood. Now, the important thing to understand here is what, like generally speaking, we say like either it's a lymphoid disorder or a myeloid disorder, depending on what kind of cells we found in the blood. So, lymphoid disorders, um, they can give they can further classified into three main things. Like one is called as leukemia, one is called as lymphoma, okay, and one is called as plasma cell, which I was talking about the myelomas, um, dyscrasias, okay. So whereas the myeloid disorders are further classified into different categories like leukemias, okay. Then there is what you can say myelodysplastic disorders, okay, as well as myeloproliferative disorders, okay. So it could be, sorry for the spelling mistake, it could be leukemia, it could be myelodysplastic disorders, or it could be myeloproliferative, you can say, disorders or neoplasms, right? So the example of leukemia of lymphoid lineage is acute lymphoblastic leukemia as well as chronic lymphoblastic leukemia, whereas the lymphomas of lymphoid lineage or disorder is like Hodgkin's. We are going to discuss, of course, all this. Then there is non-Hodgkin. Okay, like of course they are named because of the name of the cell which are present in them. B cell, because it is lymphoid lineage, so they give rise to T cell and B cell, and it could be T cell. Okay, and or there are others, okay, which we'll talk in detail. And in plasma cell dyscrasias, there is multiple myeloma, which is the most important one we are going to study. Then there is monoclonal gammopathy of unknown significance. Okay, monoclonal gammopathy of unknown significance. Then there is one of the kind called as Waldenstrom uh, macro global globulinemia. Okay, globulinemia. Okay, so if you will see over here, so all the cells are basically arising from the lymphoid lineage, the B cell and the T cell. Okay, and all this one, or a plasma cell is included in this category, because like these are the cells which give rise to antibodies. So multiple myeloma or plasma cell problems are those, like, which are forming the antibodies in the body. So if you will talk about the myeloid disorders, again in leukemias, the thing will become easy. It is acute myeloid leukemia. Okay. Then in what you can say, myelodysplastic disorders like Weaver syndrome, we are going to discuss that thing in detail. Then there is polycythemia vera, in which there is too much RBC. So remember, like guys, other than lymphoid, myeloid give rise to all the cell lines, as I told you, basophil, neutrophils, okay, eosinophils, RBCs, and all this stuff. So uh, polycythemia vera is one of the you can say myeloproliferative neoplasms. So see the name myeloproliferative. So the myeloid lineage is proliferating too much. So that's why it is called as myeloproliferative disorder. So polycythemia vera is one of them. Okay. Then there is essential thrombocythemia, in which like there is too much platelets, because platelets also arise from the myeloid lineage. Okay. Then there is chronic myeloid leukemia, and one of the thing is idiopathic myelofibrosis. So, very important thing. See, if you will understand this concept, what is how we classify hematological malignancies? What is lymphomas? What is leukemias? What is myelomas? Like this, one of the classification of hematological malignancies, of course, which is basically giving you a good view about what actually are the condition is. And here is the classification. And of course, to know this classification, you must know what are these cells. So myeloid lineage is basically the bone marrow have the stem cell, and they give rise to different blood cells. So when and we call that process as myelopoiesis. You can see over here, by the way, see this is lymphopoiesis and this is myelopoiesis, right? So you can see lymphopoiesis, these are those which give rise to the cells which are basically what you can say um, give rise to uh, B cells and T cells, okay, as well as the plasma cells. So lymphopoiesis, okay, is the process like which we call this thing, by which this thing is formed. And myelopoiesis, like there is a common myeloid progenitor, and then we need a lot of factors, of course, like which differentiate them. And see, they give rise to erythrocytes, basophils, platelets, basophils, eosinophils, monocytes, and neutrophils. So whenever there is any malignancy of this lineage, or you can say this cell, so of course it could be polycythemia vera, it could be essential thrombocythemia, it could be um, acute myeloid leukemia, it could be chronic myeloid leukemia, it could be myelodysplastic syndrome, and XYZ. And whenever the lineage, when the problem is in this lineage, so that is going to give you, what you can say, lymphoid disorders, right? Again, one more diagram, to show you what is acute acute myeloid leukemia and acute lymphocytic leukemia. Okay, so see, there is one hematopoietic stem cell which differentiate into lymphoid progenitor and myeloid progenitor. So whenever there is abnormal proliferation of this cell line, we call it as acute lymphoid leukemia, and whenever there is abnormal proliferation of this cell line, we call it as acute myeloid leukemia. Okay, so this is like how we differentiate these type of, what you can say, like malignancies. Okay, uh, a little complex, but I don't think so like too hard. So like if I will talk more about what is the myeloid disorders, guys. So for example, sickle cell disease is a myeloid disorder, thalassemia is a myeloid disorder. For example, iron deficiency anemia, it is affecting what? The RBCs, it is a myeloid disorder. Vitamin B12 deficiency anemia is a myeloid disorder. So, see, all the conditions which are related to this cell line, or you can say this cell line, of course, like they are called as myeloid lineage, right? And whenever the anything is causing issue with this cell line, we call it as lymphoid lineage is affected. Okay, so myeloid disorders are a lot, of course, right? So the classification, of course, like this is the most easiest classification you can say, which I am telling you, showing you. Otherwise, like the WHO, they give very extensive type of classifications, and different books they give a lot different type of classifications. So our aim is to, of course, uh, know the basics, okay, and know what these different type of malignancies they look like. So to start with, guys, what my plan is to um, first of all catch the myeloid lineage, and first of all we will study acute myeloid leukemia. We can study chronic myeloid leukemia. We can study polycythemia vera. We can study idiopathic myelofibrosis. We can study essential thrombocythemia, and we can study acute myeloid leukemia. Okay, and then we will catch the lymphoid lineage, and we will study acute lymphoblastic leukemia. Then we are going to study, you can say, chronic lymphoid leukemia. Then we will study Hodgkin lymphoma as well as non-Hodgkin lymphoma. Okay, so we are going to go in this way, right? In this way, of course, like we are going to make some concept, and then in the end, we are going to study plasma cell dyscrasias, and like of course in that one multiple myeloma is the most important one. We will discuss what is monoclonal gammopathy of unknown significance, and we will talk about Waldenstrom macroglobulinemia, right? So once, like of course, we will finish all this one. So like over this hematological malignancies is going to finish, right? So to start with, first of all, uh, like there is some terms which will come again and again and again, and like maybe you will be confused at some time what I'm talking about. Okay, um, for example, blast. There will be a thing which is called as blast cells, right? So what is blast cells? Blast cells are basically immature cells, right? So I'm just calling out this PPT so that if you want to stop somewhere, of course, like you can read that thing. A lymphoid organ, as I told you, there are primary lymphoid organ, bone marrow, thymus, secondary lymphoid organ like spleen, lymph nodes, mucosa. Okay, there's no lymph nodes in orbits, and like this. Okay, so this is like something history, like Wirtshaw first coined the terms leukemia and lymphosarcoma in 1845, 1863. First description of Hodgkin disease comes in from Carswell in 1928. Term Hodgkin disease by Wells in 1895, and so like much of the history is given in this one. Okay, in 2008, by the way, WHO gave a classification of hemopoietic and lymphoid neoplasm, which I was talking about. Like that is, you can say, uh, very, very, very complex type of classification. You are not required to remember that, of course. Okay, so like this is again the same classification. Lymphoid neoplasms, I explained you in another way. There is myeloid neoplasms. Again, I explained you in different way. Okay, so uh, I explain you what is leukemia. So leukemias are those which arise, like the malignant cells, they arise from the blood and they spread elsewhere. But I told you the thing is, when they found these cells, they run a lot of investigations, and based on those investigations, they classify uh, like in which category they must put that condition in. Okay, okay. See, there are two type of leukemias. One is acute and one is chronic. Okay, guys, acute leukemias are basically rapidly progressive type of malignancies, uh, in which the cells are proliferating or you can say multiplying at an enormous rate. And when the cells are multiplying at enormous rate, basically the cells which started appearing in the body, they are not mature cells, rather they are immature cells. Okay, so remember there is one term that is called as blast cells. Okay, so what is blast cells? Simply, blast cells are immature cells. Okay, these are immature cells. Okay, we call it as blast cells. So what will happen in acute leukemias? There will be presence of lot of um, blast cells which fail to differentiate into mature cells, right? Whereas chronic leukemias, they are slowly progressive. Okay, and like of course, see, one condition, when some disease is um, like evolving fast, you can say, of course they give you more mortality, more morbidity, more sign and symptoms. Whereas the chronic conditions, chronic leukemias, because they multiply slowly, so they they don't give much sign and symptoms so quickly. Rather, they show up slowly. Okay, and the survival is high in what you can say chronic conditions. Okay, now uh, generally speaking. Uh, uh, this is the overview, right? So when we once we have an overview, we will develop good concepts. Of course, it will be easy to understand the rest of the condition, right? So uh, what we are going to do is uh, see all your okay. Like one thing to make clear is I am talking right now mostly about myeloid malignancies, right? Uh, and to some extent the lymphoid malignancies as well. But what I want to tell you now is, see, when your bone marrow is producing RBCs, bone marrow is producing WBCs, and bone marrow is also producing what? Platelets. So bone marrow is the production house, okay? And there is limited capacity to produce these cells, okay? So for example, in the bone marrow there is overproduction of one kind of cells. What will happen? Mm, the other kind of cells will not be produced. And for example, uh, the one kind of cells which bone marrow is producing, and they are producing blast cells which are immature cells, so they will not function properly. So see, two or three types of things were arising. Number one, we will not get the normal cell count, right? And number second is we are not going to get the normal functioning of the cell. For example, if your bone marrow will start producing too much neutrophils, okay, uh, and not like the mature neutrophils, rather a lot of blast cells, which are immature neutrophils. I'm just giving you an example, and they're producing at too much speed that RBCs cannot be produced, as well as platelets cannot be produced, no eosinophils can be produced, and no basophils can be produced. What will happen? That your blood will flood up with immature cells, and when your blood will flood up with immature cells, the ultimate result will be what? When there will be no RBCs, what will happen? There will be anemia. When there will be no WBCs, there will be what? Leukopenia. And when there will be no platelets, there will be what? Thrombocytopenia. So most of the sign and symptoms in hematological malignancies are due to anemia, leukopenia, and thrombocytopenia. So see, or there could be pancytopenia. So now, what signs anemia or symptoms anemia give? You have already covered it. You give you pallor, it gives you uh, dizziness, it gives you palpitation, it gives you uh, fatigue and all this stuff, right? When there is no leukopenia, when there is leukopenia, what sign and symptoms you will be getting? The patient will be getting repeated infections. And when platelets will not be there, what will happen to the patient is simply there will be superficial bleeds, petechias, ecchymosis, and purpuras, right? So now when you will study the malignancies, you will found like most of the things will revolve around this thing. Okay, one thing about lymphoid malignancies is what? Whenever there is lymphoid malignancies in the body, the lymph nodes are going to swell up. Okay, And when the lymph nodes are going to swell up, these patients will present with lumps and bumps on the bodies, plus splenomegaly. Okay, and all the secondary lymphoid tissues can get enlarged as well. Okay, so see, common symptoms of leukemia, if you will see, is like weight loss, fever, frequent infections, lung, easy shortness of breath, muscular weakness, bone and joints pain and tenderness, psychological fatigue and loss of appetite, lymph nodes get swell and spleen get enlarged, and skin, there can be night sweats, there could be easy bleeding or bruising, there could be purplish patches or spots. So see, everything is understandable. If you will go logically, you will understand why it is the things which is going to which is happening. Okay, uh, generally speaking, leukemias, like other malignancies, result from somatic mutation in the DNA, and certain mutation produces leukemias by activating oncogenes, okay, or by deactivating tumor suppressor genes. So of course, like we have like uh, I'll give you the example of breast cancer, for example. You know, in breast cancers, what is happening is like some of the people, they have some abnormal genes in the which runs in their families, and they are at increased risk of getting blood cancers. So they're not just breast cancers. So they're not just like you can say breast cancers, but different cancers, they arise due to presence of abnormal genes in our body, and those are the people who are more susceptible to get those type of cancers. And uh, there are in our body some tumor suppressor genes, right? So when these genes are deactivated, what will happen? They are not going to do their action of deactivating that that thing, so which will ultimately lead to cancers. Okay, so this is how these things basically work. And these mutations may occur spontaneously or as a result of exposure to what? Radiations by certain drugs or carcinogenic substances, and which are likely to be influenced by genetic factor. So, see, things make sense, right? Here. Causes continued. Okay, there are many. You can say ionizing radiation, many viruses. They are what you can say connected to different type of cancers. And one example I would like to give you here, for example, cervical cancer in females. You know, cervical cancers, they are more like they are associated uh, with a virus called as HPV, human papilloma virus, and they have a vaccine called as Gardasil, which can be given to the females, you know, at a very young age or before they started their sexual life, you know. We can give that vaccination, and we can protect them, or not completely protection, but of course it offers a lot of protection against that infection, and these females are at less risk of getting cervical infection. Smoking slightly increase leukemia incidence, and genetic predisposition, like for example Down syndrome, Fanconi's anemia. You know, like both these things are associated, and so on and so forth. So there are different type of associations, but of course we cannot talk all the associations to all together, right? So actually, why I'm taking too much time in introduction, guys, because this is one of the topic uh, which many people, you know, they found it hard to understand. They found it hard to uh, understand the names, understand, and many medical students, you know, they just leave these topics after giving it, like you can say, one read from the book, or sometimes they don't even give a read because, you know, the things appear to be very difficult. But if you will try to learn the basics first, you know, the things will appear or will become quite easier. Okay, so leave this thing. They are just classifying on the same thing. See here they are writing acute and chronic, and the cell type, either it's lymphocytic or either it is myeloid or lymphoid. So see, acute lymphocytic leukemia, acute myeloid, or chronic lymphocytic and chronic myeloid, right? Okay. Uh, Now, one more thing. As I told you, there are different classifications. Um, One of the thing you can see over here, there is FAB classification, which is followed in this world. What is FAB? It is French, American, and British classification, right? Uh, this classification relies on, you can say again what I was talking about, like things are not so simple. Rather, uh, what they do is like they see, or they run a lot of investigations to see what kind of cell types are present. Okay, what are their cytogenetics, what is their molecular changes or immunotype phenotyping. Okay, and based on that, like they classify what kind of cancer the patient have. So now, um, there is a classification which is given by WHO as well. Okay, and WHO classification, like, oh, of course, like you can get it even in this slide. There is the classification is there, right? But of course, you can found it like even on WHO website or all the books, right? So these are the differences, what you can say between the WHO classification and French, American, British classification differences, which is there. Okay, so now, for example, I want to show you something. Mm, okay, this is the classification which I was talking about: leukemia, lymphoid disorders, myeloid disorders, and see this one and this one, right? Okay. Uh, for example, if I will talk about acute leukemias, okay, and the first thing which I'm going to teach you is acute myeloid leukemia. See, this is 2008 WHO classification of acute myeloid leukemia and related neoplasms, right? So if you will go and see it in a little more detail, what you will find that, uh, of course, like you are not required to know about each and everything in this one. It's beyond your scope, okay, and beyond many people's scope, of course, who are not hematologists. So uh, what we do is like we are going to just study one thing, that is acute myeloid leukemia. But if you can see that there is, acute myeloid leukemia with recurrent genetic abnormalities, acute myeloid leukemia with myelodysplasia related changes, therapy related myeloid neoplasms, myeloid sarcoma, myeloid proliferation related to Down syndrome. Now, Down syndrome people, they are at increased chances of getting this type of uh, leukemia, right? As well as you will see plastic plasma, cytoid dendritic cell neoplasms, and AML not otherwise specified. Uh, like it is undifferentiated M1, myeloblastic M2, promyelocytic M3, myelomonocytic M4, monocytic M5, erythroleukemic M6, megakaryocytic M7, acute basophilic leukemia, acute myeloses with myelofibrosis. Basically, they are, it's wrong here, they are the same thing. Okay, so what you can infer from this one is simply see it looks hard, but in reality, what they do, they see what kind of cells are there. Okay, see, acute myeloid leukemia give increased level of blast cells, which are the immature cells in the blood. And when we see what kind of blast cells are there, we can say that this type of cancer or this type of acute myeloid leukemia is there, right? And of course, that is based on the cytogenetics, the immunophenotyping, the molecular changes, and the histology as well as the histochemistry of the cells, right? So now the important thing is like we are going to start with acute myeloid leukemia. Uh, now, by definition, acute myeloid leukemia is rapidly progressive malignancy characterized by failure of myeloid cell to differentiate beyond blast stage. So now you know what is blast stage, right? Like these are immature cells, right? So what is happening in these patients is simply, um, uh, these patients, what is going on, that the cells, they are not differentiating beyond that stage. Okay, so what will happen in the bone marrow, there will be too many blast cells, right? And remember, blast cells are immature cells which cannot function properly like the mature cells. Okay, AML, the incidence increases with age. Median age of onset is 65 years of age. Okay, uh, and it constitute around, you can say, remember guys, one of the thing, uh, AML, okay, remember M for mature, okay. So M for mature, guys, this one is more common in old age, okay. M for mature. So acute myeloid leukemia is mature leukemia. It occurs in adults. And remember, ALL, acute lymphoid leukemia, is very common in children. Very, very easy to remember. 80% of acute myeloid leukemia occurs in old people. 65 years of age is the median age of onset. And just few of the patients you will see is the child patients, 10 to 15%, right? Because 85% of the times it occurs in old people, right? And I told you how to remember this thing. M for mature. Mature means what? AML is a condition for old people, okay? Now, the second thing to remember, uh, the risk factors is, I told you the causes of leukemias, right? And what you will found, like most of the risk factors will be same. See, radiations, benzene, um, alkylating agents as treatment for previous malignancy, they increase the chances. I will add something else over here. Remember, guys, Down syndrome. Okay, Down syndrome babies, they have increased chances of getting AML, and different myelodysplastic syndromes. Okay, they are the risk factor of developing this condition. Okay, although I'm not interested in pathophysiology much, but I wanted to tell you a very important thing, mm, a very important type of MCQ which can come in any exams, right? So you can see over here, etiology is subdivided into two things: primary and secondary. Okay, secondary is of course like when there is some other hematological malignancy. See this one, myelodysplastic syndrome. So when there is other hematological malignancies like myeloproliferative disorders, MDS, or previous chemotherapeutic agents like alkylating agents. Okay, so when simply there can be two ways. One is primary, of course, when there is no other cause you can found, and there is like some of the people they get it by presence of some factors, right? We call it a secondary. So what is going on? See, it's acute. There should be blast cells. Uncontrolled growth of blast in bone marrow leads to what? Suppression. See, whatever I'm saying, you guys, now those things will keep on repeating again and again and again. And believe me, actually, when I was preparing for different exams, like steps, like all my membership exams, uh, even I found it hard to differentiate and how to understand these things. And what I did, like I made this simple concepts, and then they helped me a lot. See, whatever I told you, things will keep on repeating again and again. See what's going on. Suppression of normal hemopoietic cells, RBCs will be less, platelets will be less, all the other normal cells will be less. Appearance of blast cells in peripheral blood, of course. Accumulation of blasts in other sites like skin, okay. The cells will start accumulating in the skin, in the gums, or so what will happen in the gums, like the gingiva or the gums are going to swollen, are going to like big in size. There are different metabolic consequences like tumor lysis syndrome. Okay, what is this thing, tumor lysis syndrome? Actually, what happened is, um, the tumor, of course, which is present in the, what you can say, in the body. Okay, any tumor I'm talking about. I'm not talking about this one. I'm talking about any tumor which is present in the body. The tumor is made up of what? Tumor is made up of cells, of course, right? So when tumor is made up of cells, okay, so what it means, what will happen is that all those cells, they have a lot of things, like for example, sodium, for example, potassium, it could have phosphate, it could have anything. Okay, so all tumors have different, like, of course there just should be something in the cells, right? So tumor lysis syndrome basically occur as a result of treatment of cancers. When we treat the cancers, is basically we are killing the tumor, we are killing the cancer, or we are lysing the cells, we are destroying the cells. So when the cells are destroyed, so and they burst off, they release all their contents into the bloodstream, into the blood. Okay, so mostly when we go for to treat leukemias and lymphomas, so what happens, like, all the cells when they lyse, when they burst, their things will spill out in the blood. We call that thing as tumor lysis syndrome. And what happens in these patients is, like, a lot of potassium is there, so they present with hyperkalemia, they present with hyperphosphatemia, they present with hyperuricemia. Okay, so what happens, like, all these things increase in the blood, okay, which can lead to hyperkalemia, can lead to cardiac arrhythmias. Okay, all electrolyte abnormalities can give fits or seizures. Okay, any kind of increase in the blood of anything can go and can damage the kidney, so they can have what, they may have acute renal failure. Okay, so now and also, they can go into hypocalcemia. Why hypocalcemia? Because when a lot of phosphate is released, okay, so phosphate bind with calcium and it makes calcium phosphate, so which leads to hypocalcemia. So when hypocalcemia is there, what happens is, like, there could be tetany. Okay, tetany can be there, and so on and so forth. So, like, this is called as tumor lysis syndrome, right? uh, if, like, we will discuss it, like, later on. I'm going to talk more about this thing, right? But I think for now, because we're right now covering acute myeloid leukemia, and I want to finish this topic in the next 10 to 15 minutes, of course. uh, so see, guys, now, okay, just to wind up all these things, I'm not going to talk about all these things again and again in every cancer. See, why anemia is there? Because there is less production of RBCs. Why thrombocytopenia is there? Because there is less formation of platelets. Okay, so why there is neutropenia? Because there's blast cells, and what is happening, that due to blast cells there is not production of enough other white blood cells, simply. Okay, or there will be no even a normal WBC, so which will lead to infections and fever. Okay, this thing will lead to petechias purpuras, and this will lead to, again, you had already covered anemias, right? So what happened, there is production of too much blast cells which are accumulated in the bone marrow. And when they are started accumulating in the bone marrow, so what happens, like, the patient, they started feeling pain in bones, especially where hematopoiesis is going on, so they present with skeletal pain. When we examine them, and uh, you can see a video of Geeky, how you have to examine someone with hematological, when, like, from hematological point of view, for example. So in that one, we perk, like, we tap on different bones, just to see if the patient have any bony tenderness. So, sternum is a very important site for hematopoiesis, so, they have tenderness, especially in sternum. Okay, now, see, as I told you here, that the blast cells will started depositing in different sites. So what will happen? See, guys, the things are easy, just you have to take them in this way. Organ infiltration will occur. See, the blast cells are going to deposit into the gums. Gingival hypertrophy will be there, and that's why many of the patients who have ALL or AML or acute myeloid leukemia, maybe they, first of all, they present to the dentist, like, they say that, our gums are becoming big, so the dentist diagnose them with AML, or the dentist will ask them to go to see some doctor, right? When the cells are going to uh, deposit in spleen, it can lead to or liver, it can lead to hepatosplenomegaly, but it is rare in AML. Rather, it is more common in acute lymphocytic leukemia, ALL. It is rare in AML, what we are covering now. So you can let it go, by the way. There could be lymphadenopathy, right? So there could be lymphadenopathy, and they can present in gonads, right? But again, this one is also, you can say, rare in AML. Rather, it's more a feature of AML. Okay. Skin leukemia cutis, we call it as. You can Google it and you can see, how it looks like. And the eye may have hemorrhages or whitish plaques or rot spots. If you remember, we study rot spots in infective endocarditis. Cotton wool spots and vision changes, they are uncommon, not so common. Okay. So, see, uh, these are the features, this one, due to abnormal cells in the blood. These are the features due to abnormal proliferation or too much proliferation of abnormal cells in the factory, in the site, in the bone marrow. These are the features which are due to abnormal deposition of abnormal cells in different parts of the body. And then there is the features. And now, guys, see what is going on. Too many abnormal cells are flooding your blood, and if you know what is viscosity. Okay. uh, um, what happens is the blood have some viscosity which help in the flow of the blood, but when a large number of cells are coming in the blood which are abnormal, basically they will make it thick, and we call it as leukostasis. Okay, leukostasis or hyperleukosis syndrome, which is a medical emergency. Why? Because there is large number of blast cells, okay, which interfere with circulation and lead to hypoxia and hemorrhages, okay, at different sites. Can cause diffuse pulmonary infiltrates, which will lead to what? Difficulty in breathing, dyspnea. It can lead to edema. It can lead to CNS bleeding. It can lead to respiratory distress because of pulmonary infiltrates. It can lead to altered mental status, okay, and also it can lead to, you can say, um, what you can say, uh, painful erection. Okay, it can also lead to painful erection. So, like the patients, who have, we call it as painful erection, is also called as um, Priya, Priapism, Priapism. Okay, Priapism. This is also called as Priapism. So, like in this one, the penis, they become erect, okay, and the erection like stays for a long time, and it is painful type of erection. It is one of the side effects, what you can say, which can be seen not just in this one disease, but like it can be seen in any leukemias. It can be seen in sickle cell disease. It can be seen in multiple myeloma and many other conditions, right? So just because of the stasis thing, right? So it is called as prepism. So this thing can occur. Okay, so why this thing is there? Due to abnormal, you can say, you can say specific gravity or viscosity of the blood, right? And now, uh, metabolic effects, which are aggravated by treatment. So what we are talking about, guys, right now is tumor lysis syndrome. I told you there will be increased uric acid, which can lead to gout, nephropathy, okay? Like kidneys can get damaged as well as gout can occur. There will be release of phosphate. What will happen? It will combine with calcium, can lead to hypocalcemia or hypomagnesemia. And there will be release of procoagulants, which can lead to disseminated intravascular coagulation. We already talked about that thing, okay? And there will be decrease or normal potassium before treatment, but increased potassium after treatment because of tumor lysis syndrome, again, which can lead to which can lead to hyperkalemia, and hyperkalemia can lead to what, guys? Remember, cardiac, cardi cardiac, okay, cardiac arrhythmias, okay. So it can lead to cardiac arrhythmia. So the thing is easy. Again and again, I'm saying, right, guys, it looks difficult, but in reality, these cancers are so easy if you will go in this way, make simple concepts, and then move on. Okay, a few of the things which I will tell you in investigations, a very favorite type of question which they ask in the uh, exams. So see, guys, it's a blood cancer, so always the investigation start from CBC, right? We go for CBC. Okay, the patients can present to the dentist, for example, with the hypertrophic gums. The patient can present with repeated infections. The patients can present with petechias purpuras. The patient can present with hyperviscosity syndrome. Anything, the patient can present with anything. So we can go for CBC. What on CBC will find? Very easy. Anemia you will find. Thrombocytopenia you will find. You will find maybe very high number of WBCs, but when you will check the cells type, so the cells will appear normal, which we'll see on the peripheral blood film. Okay, what we'll found on coagulation profile, we can do INR, activated prothrombin time, fibrinogen or fibrin degradation products we can see. Okay, uh, in case of DIC. Okay, increase LDH, increase uric acid, increase phosphate, decrease calcium. I think why. Okay, because of tumor lysis syndrome. So we always do baseline renal and function tests. So when we do the peripheral blood film, just to see how the cells look like, now this is the most important thing you have to remember. We found circulating blast with IR rods. Okay, what we found? Circulating blast with IR rods. This is the, you can say, the hallmark of this disease. And if you found any MCQ, like the patient peripheral blood film show IR rods, done. It is AML. That's it. Okay, choose AML. So we can do bone marrow biopsy or aspirate. We can do, okay. And what we found in them is, by the way, these things should be here. Okay, so we found blast cells in them. And AML, when more than 20% of blast cells are present. Normally, the blast cells are less than 5%. And then we go for morphological, cytological, immunotyping, and all these things, of course, to establish simply what kind of AML is there, right? Again, I told you, not so easy, right? But we do all these investigations, what kind of AML is present. You can see over here, guys, gum hypertrophy in this guy, very, very, very scaring looking of this one. Okay, anyhow, you can see IR rods, but I have never seen any MCQ in which they ask you how IR rods look like, right? Rather they just tell, they just ask the patient shows as a rule of Philic granules. Okay, that's it. So we found there is IR rods in this one. So this thing, and then we go for this thing. We can do chest X-ray to rule out anemia. We can do ECG, okay, and we can do MAGA scanning for scan prior to chemotherapy, okay, which is cardio toxic. Anyhow, what is the treatment now? Okay. There are two terms. One is called as cure and one is called as remission. Okay. What is cure? We say that the disease is cured when the patient's age or survival is same like the other population. If in some country people live until 75 years of age, and if they have this cancer, and after treatment, the patient is living for 75 years of age, so it means the patient is cured. Uh, so one thing is called as complete remission. So what is complete remission? When the tumor load is decreased so much that it is almost like normal. For example, if you can bring the tumor or the blast cells less than 5%. Okay, what is the mainstay of the treatment, you can say? The mainstay of the treatment is chemotherapy, okay? Because this is acute cancer, okay? So if we are not going to treat it, they can rapidly kill the patient by hyperviscosity syndrome or leukostasis. Okay, so it is like a it is a bad cancer, you can say, if you're not going to treat it. And all AML subtypes treated similarly except pro-myelocytic variant. Okay. By the way, this information, like with this translocation, okay, kind of information, if you, even if you don't remember, that doesn't make any difference. And all trans retinoic acid, ATRA, is the added to induce differentiation. Okay. Uh, Basically, there is a traditional chemotherapy which is used, and nowadays, they are using this combination therapy. Like they are, you can say, they are adding all trans retinoic acid with arsenic trioxide. Okay, again, like something which, what you can say, need a little more knowledge, right? So there are phases, how we treat. There are two phases. One is called as induction, and the other phase is called as consolidation. So what is induction phase? uh, what is remission? I told you what is remission. When you, like in remission, we have to reduce the tumor load, right? Or simply, if the blast cells are more than 20%, so we have to bring the blast cells back to less than 5%, right? So so we the induction phase of the treatment is just to bring or decrease the tumor load, okay, or to induce, you can say, complete remission of AML. So there are different regimes which are used. Okay, for example, cytarabine with anthracycline can be used. Okay, so patients, who have poor response to this initial induction phase, they have bad prognosis, of course. And what you can say, uh, uh, depending on the other, okay, this just I'm talking about the treatment related to the cancer. Of course, if someone have two less platelets, that they're bleeding, so of course you will give platelets. If someone have fever, you will give antipyretics. If someone have infections, you are going to give them antipyretic drugs, right? um, the other phase is called as consolidation. Consolidation phase is to prevent any recurrence, like to for the tumor to start increasing again. So what they do, like they keep on giving chemotherapy. Sometimes, they can do some stem cell transplantation as well, but of course, like in just younger patients. Okay. Nowadays, they started using hemopoietic growth factors. Okay, like growth factors, CSF, right? Cloning, colony forming cells. So we can use this thing, if like severe infection develops. So what we do, like what they do is, like, once they are in the consolidation phase, they keep on screening for different infections, like, because the WBCs are not normal. So they keep on doing culture and sensitivity of urine, stool, sputum, oropharynx, catheter sites, perianal region, for like just to see if the patient is developing any infection or not. If they found like fever or any culture is positive, then they start the antibiotics. Okay, and if they are bleeding, as I told you, give what you can say, platelets and RBCs. Okay, uh, so this thing should be given. And one very important thing, guys, we have to stop the metabolic abnormalities. For example, tumor lysis syndrome. If they have hyperuricemia, you can give them allopurinol, which is a drug we used in gout as well, right? So there's a lot of supportive care is used. But see, if you will see the overall treatment strategy is what the first thing is. You can say the consolidation induction phase, and which is there to decrease the tumor load, and the second phase is consolidation phase. And like supportive care is very important, right? um, we should change the color of this thing, okay, just to make it different. So uh, like whenever there is fever, start antibiotics and all this stuff, right? So that thing is important. Now, guys, this is the definition of care and complete remission. uh, the prognosis, what you can say, uh, not so bad, but like without treatment, the median survival is not so good, 12 to 24 months. And the prognosis is basically related to uh, the cytogenetics and what kind of cancer the patient have. For example, some of the types are bad, some of the types are not so bad. It also depends on the age, cytogenetics, radiation therapy, and all this stuff. Okay, so the patient who respond good to the induction phase, of course, like their prognosis is good. If the patient is not responding good to the induction phase, their the chances of their treatment is not so good. So that's all about what you can say acute myeloid leukemia. In the next lecture, we are going to start with myelodysplastic syndromes. Of course, in this one, I did a lot of you can say introduction, so that took a lot of time. So thank you so much, guys.